Hello, I'm Professor Ayhan Kuzu from Ankara University, Ankara, Turkey. As mentioned in the previous section, the extent of surgical procedures was determined by the localization of the cancer and the pattern of potential lymphatic spread. Here, minimally invasive complete mesocolic excision for colon cancer is demonstrated on the following animations. In minimally invasive surgery, surgeon's preference can be various regarding the port setup and the surgical team's position. Exploration of the abdominal cavity for the extension of the tumor, distant metastasis, and any metastatic peritoneal deposit have a crucial role in the management of colon carcinoma and must be performed before starting any dissection. The first animation reviews the complete mesocolic excision for sickle and ascending colon carcinoma. As mentioned previously, regarding the lymphatic spread, metastatic nodes are first located in the pericolic area, but this spread is no more than 10 cm from the primary tumor for all colon cancer, then into the lymph nodes following the center towards the supplying arteries. Therefore, the extent of lymph node dissection in ascending colon and sickle carcinoma includes ileocolic artery, right colic artery if present at all, which is missing about 70% of cases, and it includes the right branch of the middle colic artery with the dissection of the lymph nodes along the route of the middle colic artery. This way, all the potential lymph nodes within 10 cm distal to the tumor will be removed. A non-crushing bowel clamp is placed on the mesentery just at the ileocecal junction. This area is then stretched up toward the right lower quadrant, stretching the vessel and also lifting it up from the retroperitoneum. In almost all cases, this demonstrates a sulcus between the medial side of the ileocolic pedicle and the retroperitoneum. In order to enter the correct surgical plane between the visceral and the parietal peritoneum, visceral peritoneum covering the superior mesenteric vein is being divided along its axis. Within this embryological plane, we encounter retroperitoneal loose tissue and the duodenum, which is separated from the mesocolic fascia by sharp dissection. The dissection plane is created by traction and controtraction. The areolar tissue is created by this manipulation. The parietal plane and the mesocolon must be well preserved. Blunt dissection is then used to lift the vessels away from the retroperitoneum, opening the plane cranially up to the origin of the ileocolic vessels from the superior mesenteric vessels. Then, ileocolic artery and vein are dissected separately and ligated respectively. Having divided the vessel, the plane between the ascending colon mesentery and the retroperitoneum is developed laterally, out to the lateral attachment of the colon, and spirally dissecting the bowel of the anterior surface of the duodenum and the pancreas. Then the dissection is proceeds cephalad over the superior mesenteric vein. Duodenum is now already mobilized, parietal plane is well preserved, and finally duodenum almost completely mobilized. Right colic artery is present around 20 to 30% of the cases. If present, right colic artery and the right colic vein are dissected and ligated. According to the arcade principle, if the tumor is more than 10 cm away from the Henle trunk and the middle colic artery, there is no need to remove those lymph nodes around the Henle trunk and the middle colic artery. Then, the colic branches of the gastrocolic trunk of Henle are divided. This is followed by the ligation of the right branches of the middle colic artery and vein, respectively. In addition to this, omentum can be preserved unless it is invaded by the tumor. Traction on the ascending colon, medially and inferiorly, puts the hepatic flexure under tension and permits the separation of the omentum. Care must be taken to avoid injury to the gallbladder and the second part of the duodenum as they are encountered while the hepatic flexure is mobilized. Right side of the omentum is taken off the colon by following the areolar planes. Then the laser sac will be opened. As the gastrocolic ligament is divided, the area pyroretroperitoneal dissection, duodenum, and the pancreas becomes apparent. Once this area has been entered, it becomes clear that the only remaining attachment is the lateral peritoneal attachment along the ascending colon. This area, the white line of thought, is divided right down to the base of the cecum, and it may even be possible to completely mobilize the appendix and the base of the cecum to the midline from this direction. The colon is then dissected completely free from the underlying duodenum and the retroperitoneum and reflected entirely to the midline. This completes the mobilization of the ascending colon and the hepatic flexura. This will allow complete removal of the specimen at the conclusion of the procedure with easy reach of the colon for adequate resection and easy anastomosis. In this section, I will review the minimally invasive approach to hepatic flexural carcinoma. The extent of lymph node dissection is different in hepatic flexural carcinomas when compared to cecal and ascending colon carcinomas. The lymph node dissection for hepatic flexural carcinoma includes ileocolic artery, right colic artery if present at all, and middle colic artery. In addition to this, 5 to 8% of lymph node involvement could be detected along the right gastroeploic artery and the head of the pancreas. Therefore, the greater curvature of the stomach should be scintillized and the right side of the omentum must be included into the specimen. The dissection planes are similar with the cecal cancer at the beginning. Following the division of the ileocolic pedicle, the dissection proceeds cephalid. This allows us to remove the lymph-adipose tissue around the superior mesenteric vein. The gastrocolic trunk, middle colic vein, and the middle colic artery are dissected and ligated centrally, respectively. A gauze is placed over the pancreas. This facilitates the dissection from above. The left branch of the middle colic artery is clipped and transected. In order to remove all the potential lymph node involvement and the metastatic deposits around the gastroeploic vessels and the greater omentum, the greater curvature of the stomach was scintillized. Therefore, greater omentum together with the gastroeploic vessels was included within the envelope specimen of the complete mesocolic excision. To do so, traction on the colon and stomach permits the scintillization of the right side of the greater curvature of the stomach. The length of this separation must be at least 15 cm away the distal edge of the hepatic flexural carcinoma. Care must be taken to avoid injury to the gallbladder and the second part of the duodenum. As the gastrocolic ligament is divided, the area of pyroretroperitoneal dissection, the gauze, duodenum, and pancreas becomes apparent. The removal of the potential lymph nodes around the origin of the right gastroeploic artery can be achieved by central ligation of the vessels, which is a branch of gastroduodenal artery, which is now ligated. Now it becomes clear that the only remaining attachment is the lateral peritoneal attachment along the ascending colon. This area is divided right down to the base of the cecum, and it may even be possible to completely mobilize the appendix and the base of the cecum to the midline from this direction. The colon is then dissected completely free from the underlying duodenum and the retroperitoneum and reflected entirely to the midline. This completes the full mobilization of the ascending colon and the hepatic flexure. As mentioned before, lymphatic spread to the pericolic lymph nodes can be found within 8 to 10 cm from the primary tumor, but no more than that. Therefore, transverse colon is transected at least 10 to 15 cm distal to the edge of the hepatic flexural carcinoma. Here, I will describe the laparoscopic complete mesocolic excision to transverse colon carcinoma. The main draining lymph nodes of the transverse colon carcinoma are those along the middle colic artery. However, cancer of the transverse colon, including both its flexures and the proximal part of the descending colon, potentially has a multi-directional lymphatic drainage either to the ileocolic or the left ascending colic artery as well, which has to be considered when performing a lymph node dissection. In addition to this, for the tumors of the right side of the transverse colon, positive nodes can be found over the head of the pancreas. Tumors of the left side of the transverse colon may also metastasize into the lymph nodes along the inferior edge of the pancreatic corpus and tail. Moreover, metastatic lymph nodes can be detected in lymph nodes along the gastroepiploic arcade at the greater curvature of the stomach. Transverse colon tumor may reach the gastroepiploic arcade even by continuous growth as well. This animation shows the surgical resection margins for the transverse colon carcinoma. The dissection planes are similar along the superior mesenteric vessels and explained detailedly in the previous animations. Following the ligation of the ileocolic pedicle, gastrocolic and middle colic artery and vein dissected and ligated respectively. This is followed by full mobilization of the right side of the colon. Even for the left-sided transverse colon carcinoma, it is very helpful and even necessary to mobilize the ascending colon as well, as we did for ascending colon carcinoma for extended right hemicolectomy. After this step, the dissection plane starts with the full mobilization of the left colon and the splenic flexura. In order to do that, an atraumatic bowel clamp is placed on the sigmoid mesentery at the level of sacral promontory. This area is and stretching the inferior mesenteric vessels away from the retroperitoneum. The dissection at the origin of the inferior mesenteric artery involves a risk of injury to the autonomic nerves situated around the inferior mesenteric artery. Left ascending colic artery is ligated centrally, and the lymph nodes at the origin of the inferior mesenteric artery are dissected with the preservation of the autonomic plexus. Then, the inferior mesenteric vein is identified next to the left of the ligament of Trice junction. The vein is divided below the inferior border of the pancreas. The lymph nodes around the inferior border of the pancreas are removed. This is followed by full mobilization of the descending colon and the splenic flexura. As mentioned previously, the lymph nodes along the gastroepiploic arcade at the greater curvature of the stomach may also be involved. The tumor may even reach the gastroepiploic arcade by continuous growth. Therefore, the greater curvature of the stomach should be freed 10 to 15 cm from this arcade opposite to the tumor site at the transverse colon. This is followed by transection of the distal and proximal margin of the specimen. The distal resection margin is prepared and the descending colon is transected at least 10 to 15 cm distal to the edge of the transverse colon cancer. Terminal is then transected, which will allow complete removal of the specimen at the conclusion of the procedure with easy reach of the colon for an adequate resection and easy anastomosis. The following animation shows the surgical planes for splenic flexural carcinoma. As mentioned before, splenic flexural carcinoma has a multidirectional lymphatic drainage either to the middle colic artery or to the left ascending colic artery, which has to be considered when performing a lymph node dissection. In addition to this, lymph node involvement could be detected along the left gastroepiploic artery and along the inferior edge of the pancreatic tail. Therefore, greater curvature of the stomach should be scatenized and the left side of the omentum must be included to the specimen. The dissection plane starts with full mobilization of the left colon and the splenic flexura. In order to do that, an atraumatic bowel clamp is placed on the sigmoid mesentery at the level of the sacral promontory. Sigmoid mesocolon is then stretched up and retracted anteriorly to expose the posterior space, stretching the inferior mesenteric vessels away from the retroperitoneum. The embryological plane between the parietal fascia and the sigmoid mesocolon is then identified. This plane is avascular and easily divided. The dissection continues posterior to the sigmoid mesocolon, going laterally towards Todd's line. The sigmoid colon is then completely free and the lateral attachments can then be divided using a lateral approach. The dissection at the origin of the inferior mesenteric artery involves a risk of injury to the autonomic nerves around the origin of the inferior mesenteric artery. A meticulous dissection of the artery helps to avoid this risk. Left ascending colic artery is then ligated centrally, and the lymph nodes at the origin of the inferior mesenteric artery are dissected with the preservation of the autonomic plexus. Then, the inferior mesenteric vein within the meso of the descending colon is transected towards the distal resection margin. In order to have a proximal ligation, the inferior mesenteric vein is identified to the left of the inferior mesenteric artery, just left to the ligament of Trice junction. The vein is divided below the inferior border of the pancreas. The lymph nodes around the inferior border of the pancreas are removed, and the sponge is placed at the top of the pancreas. This allows us to find the correct planes from the Leser sac. Once the entire mesocolon of the descending colon and the sigmoid colon were dissected off the retroperitoneal plane, full mobilization of the descending colon and the splenic flexure is completed. Then, because of the risk of lymph node metastasis along the gastroepiploic artery, the greater curvature of the stomach should be scatenized and left side of the omentum must be included to the specimen at least 10 to 15 cm from the tumor at the splenic flexure. Once this layer of peritoneum has been opened, one immediately enters into the Leser sac. The sponge that is placed previously from the prior mobilization of the transverse mesocolon can usually be seen in this area. Lymph nodes on the lower border of the pancreas must be removed at this localization. Left side of the omentum is also included into the complete mesocolic excision specimen. Traction is applied to both flexure, and this allows us to find the root of the middle colic vessels. Visceral peritoneum covering these vessels is opened. Then the middle colic artery and the middle colic vein is dissected and clipped. Then the proximal and distal resection margins are transected at least 10 to 15 cm away from the edge of the tumor on both sides. As mentioned in open surgery section, splenic flexural carcinoma can be treated left or right-sided approach. In order to prevent potential complications regarding the transversodescendostomy anastomosis, the other option for the splenic flexural tumors is subtotal colectomy and iliodescendostomy. And finally, splenic flexural carcinoma can also be treated like a left side colon cancer. Extended left hemicolectomy can be performed. Now I'll describe the minimally invasive approach to descending colon carcinoma. As mentioned previously, the extent of lymph node dissection for descending colon carcinoma is different than splenic flexural carcinoma. This figure represents the surgical dissection margins. There is no need to remove the omentum if the descending colon carcinoma is located 10 to 15 cm away from the cancer or unless there is a direct invasion to these structures. In addition, for the tumors of the left colon, mobilization of the splenic flexure is essential for a tension-free anastomosis. An atraumatic bowel clamp is placed on the rectosigmoid mesentery at the level of sacral promontory. This area is then retracted anteriorly to expose posterior space, stretching the inferior mesenteric vessels away from the retroperitoneum. In most cases, this demonstrates a groove between the right or medial side of the inferior mesenteric pedicle and the retroperitoneum. Care must be taken not to damage the iliac vessels and the ureter. Cautery is used to open the peritoneum along this line, opening the plane cranially up to the origin of the inferior mesenteric artery and caudally past the sacral promontory. The pressure of the pneumoperitoneum facilitates the dissection, opens the avascular planes. The embryological plane between the parietal fascia and the sigmoid mesocolon can then be identified, that is, avascular and easily divided. The ureter is covered by parietal peritoneum and just medial to the gonadal vessels. The dissection continues posterior to the sigmoid mesocolon, going laterally. This dissection at the origin of the inferior mesenteric artery involves a risk of injury to the autonomic nerves situated on the left border of the inferior mesenteric artery. A meticulous dissection of the artery helps to avoid this risk. Dissection performed close to the artery also minimizes the risk of ureteral injury during the ligation of the inferior mesenteric artery. Then the inferior mesenteric artery is divided at 1 to 2 cm distal to the origin from the aorta before the takeoff of the left colic artery. Then the inferior mesenteric vein is identified to the left of the inferior mesenteric artery, or, in case of difficulty, higher, just left of the ligament of Trice junction. The vein is divided below the inferior border of the pancreas or above the left colic vein. Having divided the vessel, the plane between the descending colon mesentery and the retroperitoneum is developed laterally, outward the lateral attachment of the colon, and spirally dissecting the bowel off the anterior surface of the gerotas fascia up toward the splenic flexure. Once the entire mesocolon of the descending colon and the sigmoid colon were dissected off the retroperitoneal plane, the sigmoid colon is then completely free, and the lateral attachments can then be divided using a lateral approach. Medial traction allows the lateral attachment of the sigmoid colon to be seen and divided using cautery. Bruising from the pyroretroperitoneal mobilization of the colon can usually be seen in this area. Once this layer of peritoneum has been opened, one immediately enters into the space between the retroperitoneal dissection. Dissection now continues up toward the splenic flexure. Full splenic mobilization is essential indeed. There is no need to remove the omentum unless it is invaded by direct invasion. Attention is then turned to the lower attachments of the rectosigmoid and distal resection margin. Since inferior mesenteric artery is ligated at origin, Distal resection margin is at the upper rectum, defined by the blood supply. Depending on the site of the tumor, this level is more than 10 cm to the distal edge of the tumor. Here, I will review the laparoscopic complete mesocolic excision for sigmoid colon carcinoma. Figure shows the resection margins for sigmoid colon cancer. The dissection planes are almost similar with the descending colon cancer, and full mobilization of the splenic flexure is also essential for a tension-free anastomosis in sigmoid cancer. The sigmoid mesocolon is retracted anteriorly to expose the posterior space. The plane between the parietal fascia and the sigmoid mesocolon can then be identified. This plane is avascular and easily divided. The dissection continues posterior to the sigmoid mesocolon going laterally. The pressure of the pneumoperitoneum facilitates the dissection and opens the avascular planes. Blunt dissection is then used to lift the vessels away from the retroperitoneum and presacral autonomic nerves. The ureter is covered by the parietal peritoneum and just medial to the gonadal vessels. A meticulous dissection of the inferior mesenteric artery helps to avoid the damage to the nerves. Dissection performed close to the artery also minimizes the risk of ureteral injury during the ligation of the inferior mesenteric artery. The artery is divided at 1 to 2 cm distal to the origin from the aorta and before the take of the left colic artery. Having divided the vessel, the plane between the descending colon mesentery and the retroperitoneum is developed laterally out toward the lateral attachment of the colon and spirally dissecting the bowel off the anterior surface of the gyrotous fascia up toward the splenic flexure. Then the inferior mesenteric vein is identified just to the left of the ligament of Trice junction. The vein is divided below the inferior border of the pancreas and above the left colic vein. Sigmoid colon is then completely free and the lateral attachments can then be divided using a lateral approach. Medial traction allows the lateral attachment of the sigmoid colon can be seen and divided using cautery. Bruising from the pyroretroperitoneal mobilization of the colon can usually be seen in this area. Once the layer of the peritoneum has been opened, one immediately enters into the space opened by the retroperitoneal dissection. Dissection now continues up toward the splenic flexure. Splenic flexure mobilization is essential for a tension-free anastomosis. Attention then turns into the lower attachment of the rectosigmoid and cautery is used to open along the lateral side of the upper mesorectum. The dissection of the upper rectum should proceed with caution because the hypogastric nerves are tented upward and may be inadvertently injured. These nerves may be swept posteriorly before dividing the soft tissue in this area. Once the upper rectum is freed, the area of distal mesorectal transection is chosen, allowing a distal margin of at least 7-8 cm away from the lower edge of the cancer. The fat surrounding this area is cleared. Doing so, the superior hemorrhoidal arteries are divided in the posterior upper rectum. The distal division is performed using a linear stapler. The proximal division site should be located at least 10 to 15 cm proximal to the tumor because of the pericolic lymphatic clearance. It is performed by the preparation of lymphovascular pedicle first, dividing the descending mesocolon and subsequently the bowel.